Good afternoon and welcome to another session at UKIO 2021. Hope everyone's enjoying everything so far. So we've got quite a packed session just now with some proffered papers. First person up is David Bird, who's a clinical scientist in radiotherapy physics at Leeds Teaching Hospitals. And he's going to tell us about evidence of organ at risk dose reduction for anal and rectal cancer MR-only planning treatments. So thank you, David.
Hi, so I'm going to be talking about the impact of MR-only planning on radiotherapy treatments for anal and rectal cancers. And this study is part of a wider study assessing the challenges associated with MR-only planning, that's known as MANTA-Ray. So for those of you who don't know, MR-only planning is the use of an MRI scan alone to plan radiotherapy treatments. And the key to MR-only planning is that it generates a synthetic CT scan from the MRI, which provides all the same information as the CT, and therefore allows you to calculate radiation dose and also plan radiotherapy treatments. But one of the remaining challenges of MR-only planning in the pelvis is the lack of evidence in the literature demonstrating its benefit. Now, broadly, of course, compared to using CT alone, you gain soft tissue contrast, and for CT MRI pathways, you benefit from pathway efficiency and removing registration errors. But what's lacking is a clear, quantifiable understanding of the benefit, which can then be used as evidence to support the further introduction of MRI in radiotherapy. And I think it's clear that that's needed from the results of the recent IPEM UK and international surveys that show very limited radiotherapy MRI provision for anal and rectal cancers. So here we aim to assess the impact of using an MR-only pathway compared to a CT-only pathway, as used by the majority of UK centres, on anal and rectal cancer radiotherapy target volumes and treatment plans. So 17 anal cancer and 29 rectal cancer patients were recruited and received CT and T2 space MR simulation, all in the radiotherapy position with matched bladder filling and immobilization protocols. Now, the T2 space sequence was used because it provides excellent contrast for pelvic tumor identification, and it's also a suitable scan for synthetic CT generation, which we undertook using a deep learning-based synthetic CT model, which we developed and we previously described in the literature. So here's just a figure that shows an example of an axial slice of the MRI, CT, and synthetic CT of a single anal cancer patient. And you can see just visually how similar the synthetic CT and CT are. So all of the CT-only and MR-only target volumes were delineated separately, following our routine clinical protocols, with an additional GTV boost volume also delineated. And we took that from current clinical trial protocols. The target volume delineation varied slightly for rectum GTVs, where for our centre, the clinical protocol is for CT-only pathway, and so includes expanding the visible tumour to the whole lumen, whereas and that's due to poor soft tissue contrast, whereas for an MR only, also you can see the tumour very well, and so therefore only that's delineated. So in addition to this, we also delineated the following organs, the bladder, small bowel, sigmoid, and sexual organs on both modalities. So first thing we did was undertook a volumetric analysis of the differences in target volumes on CT and MRI and found that there were statistically significant target volume reductions for both anal cancer and rectal cancers. And these began with the improved visualization of the GTV, which resulted in 50% reduction in GTV volume and translated through to the primary PTV and GTV boost targets, resulting in a reduction of approximately 100 cc in the primary PTV for both anal and rectal cancers. Now here we can just see an example of the reductions where red is GTV, and blue is a primary PTV for an anal cancer case on the left and a rectal cancer case on the right, where the dotted lines are on CT only and the solid lines are for MRI. You can just see how this change in GTV carries through to the PTV. After this target volume comparison, we undertook a planning study to assess the impact of MR-only planning on doses to organs if these target doses are maintained to these smaller targets. And we planned standard clinical protocol and dose escalation treatment plans with a prescription for the standard plans of 53.2 gray in 28 fractions for anal cancers, 45 gray in 25 fractions for rectal cancers, all to the primary PTV. And then for dose escalation plans, we included a 61.6 gray boost to the GTV plus half centimetre for anal cancers, and 55 gray to the GTV plus 1 centimetre to the rectal cancers. So when we were planning it, we also set high coverage constraints to minimize coverage variability. And then we really focused on minimizing the organ doses. And we then compared the organ doses between CT and MRI plans to establish the differences between MR only and CT only pathways. What did we find? Well, for standard protocol plans, we saw a systematic, statistically significant reduction in doses for both for anal and rectal cancer treatments, both for the bladder and sexual organs, although the results in brackets were only approaching statistical significance. And it's also quite noticeable that there were no differences seen in the doses for the small bowel or sigmoid. But all of this makes quite a lot of sense when you think of the position of these organs in relation to anal and rectal tumours, which are typically at the inferior end of the pelvis and are surrounded by the sexual organs and bladder. So an interesting question here really is what would these reductions make a difference to patient outcomes, perhaps to reduce side effects? But that was beyond the scope of this study. And I think the next stage would be to assess this further with either NTCP modelling or to some clinical trials assessing patient outcomes. So we look at the boost plans, the dose escalation plans. It was noticeable that the anal rectal cancer organ dosage changes were quite different. For anal cancers, you saw that the sexual organs that were very close to the GTV, and usually included within the PTV or very close to it, had additional high dose sparing compared to CT only treatments. But for the rectal cancers, there was a much wider range of organs that had significant dose reductions. I think we can speculate this is due to the difference in how the target volumes are made for rectal cancers and anal cancers, where rectal cancer standard plan PTVs are just much larger than those for anal cancers. I think, however, for either cancer siting, it's quite clear that using MRI would facilitate either dose escalation or facilitate dose escalation without severe doses being delivered to the nearby organs at risk. So, in conclusion, here we assess the impact of MR-only planning on anal and rectal cancer radiotherapy target volumes and treatment plans compared to CT-only planning, which is standard in the UK. We found it resulted in reduced target volumes with systematic differences of up to 100 cc in the primary PTVs, and this translated to reduced doses to the nearby healthy organs, including the sexual organs and bladder. I think we could hypothesize that this would result in either reduced treatment rate toxicities or alternatively support GTV dose escalation for both sites. But ultimately here, I think what we provide is evidence that MRI in any capacity for radiotherapy treatment planning is an improvement in the personalization of radiotherapy treatments due to its improved soft tissue contrast compared to CT. And really, this should support centres in further adoption of MRI into clinical use. So I'll end there and just like to say thank you very much for listening, and I'd like to acknowledge the NIHR who funded this study.
Thank you very much, David. So that was a great presentation and a very, I think, hot topic, MRI planning in radiotherapy. So we'll move on to Victoria, who is going to tell us today about evaluating the dosimetric effect of uncorrected and AAEA-corrected small field output factors on SABR plans with multi-Carlo and Accurus algorithms. And Victoria works at Guy's. Thank you, Victoria.
Thanks, Joe. So a little bit of a mouthful there, but hopefully by the end of the presentation, you'll know exactly what we're on about. So yeah, I work at Guy's Cancer Centre, which is at Guy's and St Thomas's NHS Foundation Trust. Tried to use my, right. So we have problems in radiotherapy with measuring small fields. So our dose detectors can be on the same order of magnitude of the size of the small fields. Our small fields, the primary beam can be occluded by the beam collimating devices. And also we have problems with lateral charge particle equilibrium. And so all of these things add up to inaccuracies that we need to be able to deal with in radiotherapy. And in 2017, the IAEA released guidance on a factor that we can use to help us with our small field dosimetry. But our planning system, Eclipse, was actually commissioned in 2016, which was before this guidance came out. We're now looking for an independent MU check software for our 6 FFF SABR plans. And so we looked into recommissioning a legacy system, Monaco. And so in order to do that, we acquired output factor data that now is following the IAEA Code of Practice. And so the aim of this study is to investigate the dosimetric effect of uncorrected and IAEA corrected small field output factors and look at their influence on clinical SABR plans. And we're using the Monte Carlo algorithm in Monaco and the Acuros algorithm in Eclipse. So this is a graph to show the difference in our MLC defined output factors once we've applied this correction factor. So you can see that at 4 centimetre field size, there's little to no difference between our measured output factors and our treatment planning systems. But once you get down to 1 centimetre, there's a big difference between the IAEA corrected factor and then the Eclipse treatment planning system. So we've got 2 beam models. We've got our clinical planning beam model, which is in Eclipse, and this was modelled locally in 2016. And then we've got our Monaco model that we've used the IAEA corrected output factors. We've sent the beam data off and it's been modelled by the manufacturer. And then we've followed the AAPM latest guidance on acceptance testing beam models. So we've got our 2 beam models in 2 planning systems. And then to compare them, we're looking at point doses, so output factors, PDDs, and off-axis ratios. Then we're looking at static fields, so fluence maps and conformal plans. And then we move on to looking at VMAP plans, so conventional VMAP plans, and then SABR VMAP plans, so hyperfractionated small target volumes. So looking at point doses for source axis distance dose factors, there's very minimal difference between Acuros in Eclipse, Monaco, and our measured data. So that was good to see. And then moving on to our fluence fields. So you can see from the images there the differences, but there was again very little difference between Eclipse and Monaco and the measured data. When we move on to looking at non-SABR plans, so starting off with prostate plans, this is my little DVH here, and you can see there's very minimal difference. You can't see the difference between the lines, perhaps, except perhaps at the very high end of the PTV. So we found less than 2% dose differences in the PTV and the organs at risk in prostate plans. So these aren't our small field plans. And then looking at lung plans, we're getting slightly bigger differences in the PTV, so up to 7.8% dose differences in the PTV and up to 7.6% in the lung plans. So there is already a difference here before we've introduced the SABR. But even in the homogeneous targets of SABR, we're still getting a systematic dose difference. So we've looked at a cohort of patients that are representative of the patients that we treat at Guy's and St Thomas's. So they're mostly lung patients, but we've still got spinal met patients and liver patients in this cohort, and a scapular patient. And so there's a systematic dose difference that's seen across all of them. So that systematic dose difference is minus 4.6%. And then the same systematic dose difference can be seen across all the organs at risk as well. And that's quite a large dose difference for an independent, a potential independent MU check software program. You'd normally be looking on the realm of like 2% maximum. So this is concerning, but in terms of clinical impact, when we looked at SABR delivery, we found that actually both the uncorrected clinical plans and the IAEA corrected, so the Monaco plans, passed with gamma of greater than 95%, which is our clinical patient-specific QA threshold, and you couldn't tell the difference between them, and they also all passed at the more stringent criteria of 2% 2 mil. So then we have to ask ourselves, well, is there a difference clinically, and what would that difference be for those patients? So in conclusion, there's actually quite a lot of further work to do. So we found minimal impact from using the corrected output factor on static fields and simple plans, but there are significant differences for our PTV and OAR doses in VMAT SABR plans. So we'd like to move on to continuing to compare calculated versus measured doses of patient plans, and looking at differences in the MLC modelling for very small fields, because that's possibly where the differences arise. Obviously, we have got two different algorithms, so that needs to be taken into account. But for the homogeneous target of the prostate, we were getting less than 2% differences, so we'd expect to see the same across our SABRE plans in homogeneous places too. So thank you very much.
Thank you very much, Victoria. That was very, very informative and very interesting. So next up, I believe we have a recorded session by Lindsay Devlin, who is the research radiographer at NHS Greater Glasgow and Clyde. And Lindsay's talk today is going to be on margin reduction strategy in rectal cancer short course radiotherapy. Thank you, Lindsay.
My name's Lindsay Devlin and I'm a research radiographer at the Beats and West of Scotland Cancer Centre. And my project was a margin reduction strategy in rectal cancer short course radiotherapy. And I've got no conflicts of interest. So just a bit of background. So short course radiotherapy for rectal cancer delivers large doses per fraction. And as the rectum is a soft tissue structure, there are daily variations in the target position and also the organs at risk, the small bowel and the bladder. And traditionally, planning target volumes do include setup error to encompass the clinical target volume. But with image-guided radiotherapy and the use of volumetric imaging, this could further support a margin reduction in this patient group. So the aim of our work was to assess the safety of reducing PTV margins in short course radiotherapy for rectal cancer. And the objectives of this were to calculate the setup error margin required when using an offline imaging protocol, and secondly, to describe the effects of reduced margins on PTV volume, and lastly, to determine if a PTV margin of 7 or 5 millimetres can maintain CTV coverage on over 95% of fractions. So the patients that we included were the short course radiotherapy patients that had been planned with volumetric modulated arc therapy and had been prescribed 25 gray in 5 fractions. And on treatment, these patients had daily cone beam CT images, which were registered to bone with all shifts applied. The radiographers then assessed that the PTV of 10 millimetres covered the target and the organs at risk were as planned before treatment delivery. So retrospectively, we calculated the group setup error, so the systematic and the random error was calculated from the daily cone beam CT shifts. And then we used this information and put it into the Van Herk AL equation, 2.5 times the systematic and 0.7 times the random error. And further retrospective analysis was we created new CTV to PTV structures, and these were PTV of 7 millimetres and PTV of 5 millimetres. And then 2 radiographers retrospectively assessed the coverage of all of the PTV margins on the patient's daily cone beam CTs. So looking at our results, we included 40 patients in the analysis, and then we analysed 200 cone beam CT images. The median age of the patient group was 70, and the split of the patients, we had 14 females and 26 males. The rectum level that was being treated was upper for 10 patients, mid for 8, and lower for 22. This is an example of PTV margin structures on one of the patient's images. So if you can see on the CT planner scan, you'll see that there's a white delineated GTV, and beyond this, we've got the pale yellow CTV. And the red margin represents what the patient actually had on treatment, so that was a PTV of 10 millimetres. So inside these two structures, you can see that there's a 7 millimetre margin, which is delineated in pale purple, and a 5 millimetre margin is delineated in pale blue. So what we did retrospectively was we looked at all of these structures and whether these covered the patient's CTV on the daily cone beam CT imaging. So looking at the results for the first objective, and this was to calculate the setup error margin required when using an offline imaging protocol. We calculated the group systematic and random error and put this information into the margin calculation. And what we found here was the margin that would be required for setup if we weren't daily imaging these patients would be between 8 and 9.5 millimetres. And for the second objective, which was to describe the effect of reduced margins on PTV volume, if you look at the figure 1, which is distribution of the PTV volumes, what we found between the volumes of 5 millimetres and 10 millimetres, This gave a reduction of around about 30% of the overall volume. And then from 10 millimetres to 7 millimetres, this gave an overall reduction of around 20% of the whole treatment volume. So the third objective, which was to determine if a PTV margin of 7 or 5 millimetres can maintain CTV coverage on over 95% of fractions. What we did here was we looked at the proportion of the CTV coverage failures. So for PTV7, we found that this failed to cover on 5 out of 200 of the fractions, which was 2.5%, and this occurred for 3 of the patients. And for this happened on 1 out of 5 fractions for 1 of the patients and 2 out of 5 fractions for 2 of the patients. And looking at this proportion of coverage failures for the PTV margin of 5 millimetres, we found that this failed to cover in 9 out of 200 fractions, and this occurred for 6 of the patients. And the split of this, there was 3 patients this happened for 1 out of their 5 fractions, and this happened for 3 on 2 out of 5 for the other 3 patients. So in summary, what we found was 97.5% of fractions, the CTV was covered by PTV of 7 millimetres. And because this was retrospective analysis, in the online situation, we could have taken action and been able to troubleshoot to further improve the coverage. So issues such as bladder filling, rectal filling and gas, where in situations we may have got the patient off the couch, and also set up positioning. Because with reduced margins, the impact of things like pelvic tilt can have more impact. And also in the online situation, we may have done further soft tissue matching to improve coverage. So in conclusion, we found that daily cone beam CT is essential for short course radiotherapy patients. We found that the 7 millimetre CTV to PTV margin covers the majority of patients, and this could be further improved with improved bladder and rectal preparation. And because this project was retrospective analysis, we don't have any clinical outcome data to support this. But our future plans and the implementation of this work is to collect prospective patient-reported outcome measures. And I'd just like to say this has been a multidisciplinary piece of work, and I'd like to thank all my colleagues for supporting this project, and also thank you very much for listening.
Thank you, Lindsay. So next up, we have a talk by Victor Xing-Chung Lee, who is a physicist at the Royal Surrey County Hospital. And Victor today is going to tell us about a survey of UK adaptive radiotherapy practices for head and neck cancer patients. So thank you very much, Victor.
Good afternoon, everyone. My name is Victor, one of the physicists from Royal Surrey County Hospital. Today, I'm going to present the result of a survey of UK adaptive radiotherapy practice for head and neck cancer patients. I have no conflict of interest. The aim of this survey is to provide the evidence on how we perform the adaptive practice across the country and try to identify the main barriers for the clinical implementation of adaptive radiotherapy for head and neck cancer patients. In December 2019, our online questionnaire has been designed, which consists of 23 questions, was sent to all UK radiotherapy centres. There was 67 in total. This covered the general information to current ART practice and perceived barriers for implementation. At the end, there were 32 radiotherapy centers respond, with 1 radiotherapy center excluded due to its location, is being outside UK. And also on the map, you can see the centers are widely spread out across the country. The overall responsible rate was 46%, with 29 NHS centers and 2 private centers. 90% of the responding radiotherapy centers are performing ART in the UK. Because there are so many questions in the questionnaire in here, just summarize the important questions. So let's have a look at the current status of radiotherapy center. So there are more than 70% of the radiotherapy center in UK. They are treating between 50 to 200 head and neck patients in a year. And for those radiotherapy center, looks like more than 80% of them has treating between 1 to 20 patients who required adaptive radiotherapy planning for them. But this question didn't catch how many head and neck patients which actually require for assessing ART, but may not at the end to have ART. So the number could be higher. So what are the main reasons for performing ALT? So you can see the 4 main reasons for performing ALT. The first one is the rate loss, second one is the cell gap, and the third one is the anatomical variation, such as tumor shrinkage of OAR shrinkage, and also OAR tolerance, like the spinal cord, which the tolerance that could be another reasons for performing ALT. So what the imaging approach are they using for the radiotherapy centers? Most of them are perform ALT using an online approach. So either using online bony matching alone or online soft tissue matching alone or both together. So how about the adaptive strategy they are using? That is about 68% of our radiotherapy center, they're choosing using offline ad hoc alone approach, which means they're using adaptive radiotherapy when they are required. So using offline can give them a little bit time for assessing based on the individual cases. But no center are using on library pen alone or daily repenning or online repenning alone strategies. So when actually this adaptive radiotherapy will happening for those kind of head and neck patients. So most center they respond saying this this would normally happen between week 3 or week 4 during the head and neck standard regime 30 sessions treatment. So, and also what kind of imaging we're using for assessing those adaptive radiotherapy. So, so most of the center, 70% of them are using CBCT alone to assessing whether they require adaptive or not. And 6 of the other centers are using CBCT either with KV-EPID or MVCT or standard CT to assess whether they require adaptive radiotherapy. That shows us the CPCT are widely using in the country. And also, how long does they take them to perform a new adaptive pen? So nearly 70% of the center takes about 2 to 3 days to produce adaptive pen, and while 20% of them need more than 3 days, but no center can create an adaptive pen within a day. So the most time consuming for adaptive radiotherapy are the target volume and OAR recontouring. So this figures shows the target volume recontouring was more likely carried out by the doctor, and the OAR are more likely to carry out by treatment planning staff. So apart from the manual recontouring for both the target volumes and OARs, the deformable registration software are the second highest be using for assisting target volume and OAR recontouring. And also some centers are using the auto-segmentation software and AI software for assisting as well. So what kind of CTV margin or to PTV margin are we using when we perform the ART? So 95% of the center are using the margin between 3 to 5 millimeters, which is a kind of similar what we're using for standard PTV margin for head and neck panning. So do those centers perform QA before they start adaptive radiotherapy for the head and neck patients? 100% of the centers are perform QA before they start adaptive radiotherapy. The top 2 solution they're using the second independent dose calculation and also the phantom measurement. So most centers are likely to using 2 modality together, and some center using 3 modality together with the EPID to perform QA. And what are the current barriers for those centers to perform more ALT? As you know, most ALT are very time-consuming and very heavy workload. So the staffing is the key factors to perform, the main barrier for them to perform ALT. And also the lack of clinical evidence was the second high one. And the other barriers like the limited equipment, limited finance resources, limited capacity on the CT scanner, and limited QA solution, and also the image quality are also the reasons for them not to perform more ALT. So how about the automated in adaptive radiotherapy, which can speed up the process and also any future plans? So unfortunately, there's no responding radiotherapy center was using fully automated process to perform ART. The majority was using an unautomated process, and 50% of them were using a semi-automated process. How about the future plans? 13 centers said that they have plans to develop more ART, while 7 centers say no. The majority of them to have plans are either moving forward to the automated process or buying the mRNA or eFlow system. So, for conclusion, although 90% of radiotherapy centers do perform adaptive radiotherapy, there is no consensus in adaptive practice for head and neck cancer patients across the UK. This survey indicates national guidance for ART implementation for head and neck cancer patients may be required. So thank you so much for your attention. If you have any questions, you can email me. So this survey was funded by NIHL for my predoctoral clinical academic fellowship last year. And thank you so much for all the centers who participate in this survey. And also thank you for the following people helping me, like Andy, Giuseppe, Alan, Gail, Liz, and Andrew. Thank you so much. That's it for my presentation.
Thank you very much, Victor. Can I just point out that at the end of this session, there is a chance to do a Q&A with all of the presenters. So if anybody does have any questions, please, if you could just put them into the question section on the screen. So next up, we have Daniel Sanders, who's a radiotherapy physicist at University College Hospital, London. And he's going to be telling us about his investigation of latencies for a visual biofeedback system on the Elekta Unity MR-Linac. Thank you very much, Daniel.
So, hi, I'm Dan, and as you say, I'm a radiotherapy physicist at University College London Hospitals. Previously, I took part in some work at the University Medical Centre Utrecht, investigating latencies for a visual biofeedback system for the Elekta Unity MR-Linac. So, as a bit of background, at Utrecht, there are currently 2 Elekta MR-Linac systems, and these systems enable the use of MRI for real-time tumour motion estimation. Additionally, there's an MR-compatible in-room monitor, and that's just a screen which can be used to provide information to the patient. The screen's visible to the patient when they're lying head-first supine for the use of the prism glasses, which are just shown on screen there. And combining these 2 factors, the ability to track real-time tumour motion, as well as the ability to provide information to the feedback to the patient, we aimed to provide a visual biofeedback system. So visual biofeedback in this context is about providing visual information as direct feedback to the patient about the position of their anatomy, specifically about the position of the tumour. And we wanted to use this feedback for real-time patient-assisted breathing modulation for respiratory gating during treatment. So this helps to keep the tumour within a known region so we can maximise therapeutic effect while minimising toxicities. An important factor for the feasibility of a system like this is minimising the latency between what happens on the couch and how quickly the patient can see that represented in room. And so the first thing we investigated was latency. So our first imaging workflow was based on streaming to the AutoView console, which is just the section of the Philips MR console, which is in the control room. And the idea here was that it would be a simple, easily implementable, no hardware required system where you can use commercially available software for screen cloning, and the clone screen could then be fed back into the room, onto the in-room monitor, and that would act as a form of biofeedback. However, the Philips console wasn't actually designed for this use, and so an alternative workflow was also investigated to assess latency. The second workflow streams the raw reconstructed MR data directly to a research PC, as well as potentially reducing latency. This setup gives flexibility for processing, as well as having reduced loss of fidelity that's associated with displaying on and then cloning from the AutoView console. So it gives us more flexibility as well as more fidelity. So those are our 2 potential workflows, one using a copy of the control room monitor and the other using an additional PC setup specifically to stream raw image data. So previous work had described the latency associated with the research PC setup, but I aim to replicate these results as well as compare them to the latency from the naive kind of image cloning workflow. fantastic. So we've got these two. How do we actually compare the latency for each? Well, to measure, we used a 1D breathing phantom with a fixed period to provide low latency, so sub-millisecond reference position data, while doing a one-dimensional sinusoidal motion. This reference position data provided by the platform then acted as a gold standard for where the phantom was. And in each of the previously described workflows, either in-house software or a separate architecture in the research PC was used to provide time-stamped image data of the phantom as it moved, as it was represented on the MR images. So latency could then be determined by looking at the phase difference between the time position curves of the in-room on the phantom motion as provided by the motion platform and comparing that to the position derived from the MR images. So for the research PC setup, which is shown in black here, the latency was found to be between 50 and 105 milliseconds across our range of MR sequences. So that's T1 GRE sequences at 4, 8, and 12 hertz, and then a further BFFE sequence at 4 hertz. So for the screen cloning shown in grey, you can see the latency for the same sequences was increased considerably by between 105 and 213 additional milliseconds of latency. For all of these sequences, there are sub 20 milliseconds of jitter. And so with an interest in minimizing the latency, it looked like the screen cloning workflow was consistently worse performing. And so the research PC setup was preferred. So now with a better understanding of the latency involved in providing biofeedback, the efficacy of the biofeedback itself was assessed. So we had 5 healthy volunteers and we provided them with and without biofeedback to provide easily interpretable data for the patients. We did to extract position data from the MR image. We took, as shown on screen, we deformably registered the image to a single reference image, and that was used to create a vector field. And then within a region of interest, so the red square here, that was the average of the vector field within that was used as a proxy for the motion. And then this was displayed back to the patient. So we can see here, this would be an example of the screen that would be shown to the patient with a blue scrolling position trace. These should be playing, but I don't think they are. Anyway, so the first trace, you can see the motion of the patient, and this was an example where a patient wasn't shown the trace. It was just tracked to keep track of the patient's motion over time. And then in the second one on the right-hand side, this image was shown to the patient as biofeedback, as well as the green overlay, and the patient was asked to keep as best they can the position of themselves within that green overlay. It's important to note that the y-axis scaling for this is identical for both. So you can see that there's clearly reduced variance in patient position associated with providing this biofeedback. So overall, the gating efficiency, so that's the amount of time that the patient keeps themselves within that green gating, was increased by between 24 and 58 percentage points when providing biofeedback as opposed to when not. So to summarize, screen cloning was found to be easily implementable, and it offers a potential solution to visual biofeedback. However, the use of an intermediate research PC to stream raw data is recommended due to substantially reduced latencies, a slight reduction in jitter, and the fact that it provides higher fidelity data while allowing more advanced post-processing. Finally, as demonstrated, we found that by providing visual biofeedback, there was a considerable improvement in a considerable reduction in the motion of the patient. And that's enabled by the low latency workflow that we created. That's everything from me. Thank you very much for listening, and I'll take your questions at the end, if there are any.
Thank you, Daniel. So our final speaker of the session this afternoon is Dr. Ashley Poon-King, and Ashley is a specialist registrar in clinical oncology at the South West Wales Regional Cancer Centre. Ashley today is going to talk about introducing and managing the spleen as a standard organ at risk in the radical treatment of upper gastrointestinal cancers in South West Wales. Thank you very much, Ashley.
Sorry, I was on mute. So good afternoon, all. Thank you very much, Joe. So I'm here to discuss how we've introduced and managed the spleen for these patients and managing their risk of radiotherapy-induced hyposplenism. So I don't have any disclosures. So just an outline of the discussion today. I'll be first briefly talking about why we need to introduce this pathway and describe the two different groups that we looked at. So we both looked at the retrospective patient cohort, so patients that have previously been treated, how we identified them and managed their risks, as well as prospective patients going forward. So all patients due to receive radiotherapy in the future. So a bit of background, the spleen is an organ that sits in the upper abdomen, and it's important in maintaining the immune function of the body. Essentially, patients we know that have had splenectomies in the past are at increased risk of developing overwhelming post-splenectomy infection due to infection from encapsulated organisms as listed below. Hyposplenism is considered an acquired disorder of the spleen function, and there are several different diseases that's associated with. This can sometimes be associated with a reduced spleen size, but not always. And there is no sort of standard diagnostic technique to assess spleen function. What we do know, however, is the spleen is a radiosensitive organ, and exposure to radiotherapy can impact on its function. There was a large childhood cancer study of over 20,000 patients that looked at the long-term impact of splenic radiotherapy. And what we do know is that there's a dose-dependent relationship with this. So the higher exposure to radiotherapy doses, the higher the risk of relative risk of infection-related mortality. So we know for patients who've received a dose greater than 10 Gray, they are particularly associated with a risk of greater than 5%. So the RCR have issued these draft guidance, basically outlining the management of patients who may receive radiotherapy to the spleen. What they recommend is for these patients receiving a mean splenic dose of over 10 Gray, that they're considered to be put on lifelong prophylactic antibiotics and considered for post-splenectomy vaccination, and the importance of education and information to the patient and their GP. So in terms of our retrospective patient cohort, we looked at all patients who'd received a radical dose radiotherapy for gastroesophageal cancers between January 2016 and August 2020. And we included pancreatic cancers from January to August 2020. The spleen was then retrospectively sort of outlined by the clinical oncologist and then replanned kindly biophysics department. So of the 117 patients identified, just over half of them had received a dose of greater than 10 Gray. Only one of the 12 pancreatic patients, however, had received a mean splenic dose of greater than 10 Gray, and no patients had received a mean dose of over 40 Gray. So for our team, this equated to approximately 13 patients per year requiring hyposplenism risk management. So all of these patients were contacted either via telephone or as part of their routine follow-up if they had imminent follow-up, informed of the findings and provided with written information. And we also corresponded with the GP. So in terms of our prospective patient cohort, we wanted to design a seamless pathway that fit into the existing treatment algorithm for these patients. We included all patients who had treatment for the lower third of the esophagus, pancreas, or stomach, and ensured that they were initiated on prophylactic antibiotics at the end of their radiotherapy treatment and vaccinated as per post-splenectomy protocol. This was done 3 months after the end of their radiotherapy treatment in discussion with their GP. So in terms of the treatment pathway, we sort of ensure that patients were informed at the outset and at the start of their treatment. So as part of patient consent, we were standardly including hyposplenism as a potential risk and informed the patient that depending on what we found when we had their plan verification, they may require additional vaccinations and antibiotics. And actually, the RCR have now issued standardized consent forms and included hyposplenism as one of the points of discussion that need to be included. So then we went to identify the patients, and that's at the CT simulation and plan verification part of the pathway. And so once the plan verification comes through to the clinician, all patients who had a calculated mean dose of greater than 10 Gray to the spleen, spleen, we contacted the secretaries to ensure that appropriate correspondence is sent to the patient and the GP, as well as our treatment radiographers, ensuring that they are added to our hyposplenism database and arrangements are made for them to be counselled appropriately. So this is a mock-up of the correspondence that is a template letter sent to the GP. This was designed in conjunction with our GP colleagues, so the GP Macmillan lead, as well as a GP with a special interest in oncology, and to ensure that we have all the relevant information included. And this is a mock-up of the letter that we send to the patient, just informing them of the calculations that we've made and the need for counselling, etc. And this is just a copy of our hyposplenism database, just so we're keeping track of all of our patients, ensuring that they are added to the counselling sort of part of the pathway. So in the terms of the counselling, this is done kindly by our review radiographers at the start of their treatment. They complete a counselling checklist and they're provided with the appropriate written information, both a trust leaflet, patient alert card that they should be carrying with them at all times, as well as prescription for their prophylactic antibiotics, which are to start at the end of the radiotherapy treatment. And then finally, patients are often reviewed 3 months after the end of radiotherapy treatment. The clinician just confirms that if they have received this high dose of radiotherapy to the spleen, that they are being appropriately managed. And we are piloting our first 10 patients just to ensure that the appropriate vaccination appointments and prescriptions are in place, which seem to be all working. And so this is a copy of our pathway. I'm just summarizing how the patients identified and managed. And finally, I just want to acknowledge the entire team. This was very much an interdisciplinary effort involving oncologists, physicists, GPs, medical students, clinical nurse specialists, just to ensure that at every part of the pathway, patients are appropriately identified and managed. Thank you very much for your time.
Thank you very much, Ashley. I think that was very, very informative. And like you say, you've very much covered the whole patient pathway there with the work that you've done. So basically, we can invite the whole panel back up to the screen for any questions that anybody would like to put towards them. We do have one question so far for Victoria. And this question is, Victoria, why didn't you do all the work in Eclipse?
Now, that is a good question. So we were looking to commission an independent MU calculation software. So Monaco gives us the independence, but also Eclipse doesn't allow you to enter beam data smaller than 2 by 2. So we wouldn't actually be able to see the effect of these IAEA corrected output factors, because we wouldn't Eclipse, even if you can enter the data, it doesn't use it. So yeah, that's why Monaco was the starting point for this investigation. Yeah.
Thank you. And I don't think at the moment we don't have any more questions posed on in the discussion box. So if anybody does want to pose a question, please pop it in there. But we were, as a panel, we were just chatting in the green room, as you say, earlier. And I believe, Victoria, you have a question for Daniel. Is that right?
Yes, Daniel, why don't you just use an off-the-shelf solution? Why have you gone to all this effort? It sounds great, but yeah.
There we go. So it depends what exactly you mean. Do you mean a off-the-shelf product for splitting video and sending it straight back into the room? Because one of the main,
for like monitoring a patient's position during feedback, can't we just give them a line RT and then you don't have to go through any like regulations of your medical devices? Or does it not work in an MR, Linac?
So the main thing is using one of the big benefits of the MR Linac, which enables us to do MR live during treatment. One of the things that I saw while I was out there, which I found really interesting, was the ability to watch by doing rapid MR throughout a treatment how much patient anatomy kind of drifts, and that isn't necessarily represented by kind of external body motion. So yeah, it's utilizing the fact that you get this at depth motion, which should hopefully be the most accurate representation of the tumour position at any given time. I think, does that answer your question?
Yeah, brilliant. Thank you.
Perfect. Cool. Thank you.
I think, yeah, sort of just the point you sort of make there, Daniel, is that, no matter what we're doing and how sort of precise we're aiming to be, we're dealing with living, breathing people who are constantly changing. And it is sometimes very, very difficult to sort of replicate what we want to replicate, because radiotherapy would be really straightforward. If we could create that shape that wouldn't move, that we could deliver the treatment to. But certainly I've seen that as a radiographer, sort of the more sort of coaching patients, especially, just the more information like that, but certainly visual feedback certainly does help. But we don't have any more questions there to ask. But Ashley, if I could just, it's more of a sort of discussion point, and we sort of had we were involved in a session this morning where we were chatting about information to primary carers and GPs, and obviously the work that you've done, you have had to integrate with those primary carers. How did you find that? Were they sort of very much on board with sort of what you were trying to do, and so were lines of communication quite easy to sort of facilitate?
Oh, definitely. So we worked with Dr. Gemma Eccles. So she was the GP Macmillan lead, with obviously thinking from an oncology perspective in primary care. And it was fairly easy to kind of set up meetings with her to discuss the types of information that we needed to kind of relate to the GP. In addition, the work that we had done on the retrospective series was very helpful for her, just in terms of commissioning and that sort of thing, thinking about how many numbers is this going to have to be, that the GP services would have to deal with. Very, very useful suggestions in terms of the practical aspects of what sort of information needed to be included. Because of our pathway, timing is very important. And often we have so many different steps in oncology, it's very difficult for the GPs to kind of keep on track with what's going on. So I think the feedback that we've had is, so far, because we correspond very early and we give them, okay, this is our schedule, this is our plan, these are the exact dates that we need to work to in terms of starting the antibiotic, in terms of starting the vaccinations, we're finding actually that patients are in their first week of radiotherapy and they already have an appointment for their vaccines 3 months down the line. So it seems to have worked really, really well.
Yeah, and very important again for supporting the patients. It's, like you say, very, very comforting for them to have that prior knowledge. So now I don't think we have any more questions. I think everybody's all questioned out today. So I think I'll just wrap this session up and just thank you all once again for a very, very informative session. It was all, I've learned a lot. So thank you so much.